Plenary 2. This session is entitled Making an Impact in Women's Health, a Call to Action workshop. So please be ready for action. I know our speaker is ready and ready to go. For this session, our presenter is Kun Deepti Saraf, General Manager of Roche, Malaysia. I'd like to also mention that Kun Deepti used to work in Bangkok for a number of years, so I'm sure many of you are familiar with her. She works here with various patient groups and health authorities in Thailand.
And the other speaker in this session, Associate Professor Dr. Youwanuch Kongdan, President of Thai Breast Disease Society. Unfortunately, she is not able to attend the APPC 2022 in person, so she's kindly sent us a pre-recorded presentation. And you can find her biography on the 4th Asia Pacific Patients Congress page on iApple's website.
Right. Now, before we actually get started, I would like to invite you to submit questions, whether you're attending in person or online. Online attendees, of course, you can send your questions via the Q&A tab on the virtual stage. And now, we would like to invite Kun Deepti Saraf on the stage. But before we get started, now to get this workshop going, we would like to ask a couple of questions. And if the answer is yes, please stand up. And for those of you online, you can use the raise hand functionality for this. So the first question, how many women here are cancer survivors? So if the answer is yes, please stand up. And question 2, how many of you have immediate female family members, distant relatives or friends who were diagnosed with cancer? Please stand up. Oh, wow. Yes, indeed. Yeah, there are many. So now, Kun Deepti, I see you also standing up. So perhaps you might like to share with us your story and presentation. Kun Deepti Saraf.
Okay. Yeah. All right. Thank you.
All right. Thank you. And please be seated.
And a big round of applause to all those who were standing up. Cancer is no joke. So congratulations on being the brave survivors or having relatives who had cancer. I'd like to share my little story, and I have had cancer in the family too, and I'd like to share a little bit about that. The story of every woman, but this woman is my mother, my tiger mom. My mom is the rock, the pillar, the foundation of our family. I'm sure like all our mothers are. Never have I seen her rest because of a stomachache or a headache or a flu or period pain. I have never seen her take a day off. Also because she's the caregiver of my dad, who is congenitally detected to have asthma and also COPD, pulmonary disease. Because of which my mother has taken that extra role of being the strong one, the brave one, supporting my dad through his journey. As years passed, we've always seen my mom strongly stand behind my dad. But 2 years ago, during COVID, my mother was diagnosed with cancer. It was a big time for our family, very, very difficult, very, very challenging. But I'd like to share a little bit about her journey. The first time that she had abnormal symptoms, she decided to ignore it because, it's woman, things keep happening, and what's the big deal? And even though this was a symptom that shouldn't have happened, and it was happening 10 years after her menopause, she still decided to ignore it. The second time the symptom happened, she knew something was wrong, and she decided to take an appointment with her gynecologist. But on the day of her appointment, my dad complained of a little flu. She cancelled her appointment and never got to redoing the appointment. So basically, she prioritized my dad's health again over her own health. Luckily for us, she had a chance encounter with a gynecologist in one of the markets. She decided to discuss her symptoms, and that's when she realized that it had to be taken seriously. Despite me being in the industry and working with Roche, which is largely an oncology company, it took us 7 doctors. It took us 5 months and 4 different hospitals to get her diagnosis right. And even when we got it right, and she got the best doctor to do the surgery for her, it was a robotic surgery. The insurance company decided to not give us the claim because robotic surgery, even though her age sort of precludes her from having any other form of surgery but robotic, the insurance company was not understanding this. After the surgery, she really had to go through multiple rounds of radiotherapy, and very little support was available in terms of questions and the psychological impact of having cancer. She really did not know who to reach out to, who to talk to, what needs to be done. She had multiple side effects because of her age and also because of the radiotherapy. And till today, she lives with a swollen leg, affecting her quality of life on a day-to-day basis. Now, I ask you as healthcare, people in the healthcare system, that even though my mom got the best care and perhaps at the right time, does she really have the right quality of life? Does she have the outcomes that women in society deserve? And the answer to that hopefully is no from all of you. And this is not just my mother, right? I'm sure you as cancer survivors and your relatives, all of you have similar stories. Women prioritizing their family, women prioritizing social life, all kinds of things, their husband, their children, their dog over themselves. Women not getting access to good quality care, women not getting access to high quality outcomes. And so therefore, women's health is a key topic for us, and we are in 2022 and we are still discussing this. Women form 50% of the world's population. We are 3.8 billion people. Some of us have high propensity to certain diseases. In fact, there are certain diseases that affect women more than they affect men, and most of them have very, very high burden, not just on the woman, but also on the family and on the society. 75% of autoimmune diseases are found to be in women. 50% of all cancer incidences are in women. Lung cancer, breast cancer, cervical cancer are the top causes of cancer and affect largely women as well. Despite this, women face inequities in healthcare. If you look at how HCPs dismiss concerns raised by women, you will find that women's concerns are dismissed twice, 2 times more than that of men. Misdiagnosis is seen more in women than it is in men, whether it's in cancer or in heart diseases. So clearly, we are being dismissed as women in the healthcare system. Only 5% of global healthcare assets are dedicated to women. And this is despite the fact that we are 50% of the global population. Now, we all know that women are at the core of healthcare. Women are at the core of society. Women are at the core of a family. Most women are the decision makers for their family. Most women they are the ones responsible for spending on healthcare in the family. We also know that improving women's health leads to an improvement in societal health, leads to an improvement in the healthcare system, because as I can see here in this room, most healthcare providers, nurses, patient advocacy groups, caregivers are all women. 66% of caregivers are women compared to only 1/3, that is 33% being men. We also know that if you target women's healthcare, you can have huge societal and economic benefits. We are talking about investing $300 million in three diseases could yield $13 billion in economic returns for society. So clearly, investing in women's healthcare has huge societal as well as economic impact. Even the WHO recognizes this. And in the World Economic Forum and the WHO Forum, they spoke about improving the global health outlook for everyone will require a specifically women-centric approach to integrated healthcare services. So clearly, women are at the core of healthcare, and yet we do not have the best healthcare. Let's see a video that we've put together about these issues that women face.
For far too long, women have been overlooked in healthcare. Women can take years longer, wait years longer to get the correct diagnosis. Today, women are still not equal to men in research and its funding. Because science has too often seen men as the default human. We can no longer wait. It's time to close the gap and change the facts in women's health. X Project.
Now you may ask, what is Roche doing and what am I doing, since this is also so personal to me? So I'd like to share with you a little bit of what we are doing in women's healthcare. Firstly, we are prioritizing women living with cancer. And not only because cancer is the leading cause of death, it's the #2 cause of death globally for women, but also because cancer is not just a disease. It affects all parts of women's lives. It affects the psychological, spiritual, it affects the economical, societal, all kinds of aspects of life. And if you look at the Lancet study here, what is not acknowledged is the disproportionate impact of cancer on the lives and livelihoods of women. Now, this is true for cancer as such. And then within cancer, we have decided to focus on breast and cervical cancer. Again, because it's the highest incidence in women. In most countries, in 104 countries, breast cancer is the #1 cancer. In 23 countries, cervical cancer is the #1 cancer. So clearly it has the highest incidence. But not just because it has the highest incidence, we also see gaps even today in breast and cervical cancer journeys, because 900,000 deaths that are seen in cancer, in breast and cervical cancer, are actually premature and actually could have been avoided if something could have been done with these women early on in the journey. So it is a cancer that is high in incidence. It is also something that is leading to premature deaths, and we do not want that anymore for women. It's also one of the cancers that primarily affects APAC, Asia Pacific as a region, and we are very passionate about changing the way women live with cancer in Asia Pacific. Now, as we started on this journey, the first thing what we wanted to do was to really understand what women-centered cancer care could look like. And for this, we did a lot of survey amongst multiple markets across different continents in the world. We interviewed policymakers, we interviewed patient advocacy groups, we interviewed patients themselves, we interviewed influencers, HCPs, and we found out that there are 4 different things that women want from their cancer care. The first one is holistic care. Women want a one-stop shop for cancer care. Cancer is not just about the treatment, it's about the psychological impact, the mental impact, the aesthetical impact, spa therapy, and everything. They want it all together so that it's like a one-stop shop for them when it comes to cancer care. They want cancer care which is individualized. They want cancer care which can protect or identify, and we were talking about the 5 Ps earlier. They want cancer care which is predictive, which can identify their risks early on, but also recognize that they live in a society which is full of pressures on women. So how do we individualize their journey and make it easier for them to navigate their societal challenges? Women want cancer care which is also family-centric. They need you to recognize that they are parts of the family and they need to prioritize their child care and their family lives. And how do you make sure that their care is more flexible, closer to their home, closer to their communities, so that they can manage their family lives while taking care? And women want to be more empowered in their journey towards cancer care. They want to know what is happening to them. They do not want to be beneficiaries of decisions being made on their behalf. They want to be participatory, which means they want to make the decisions themselves. So this is what we identified through all these, and I think you know this better than me as patient advocacy leads and people who have lived with cancer or have people who have cancer in your families and friends. They, let's go back to my mother's journey. Now imagine if predictive analysis was available and my mother, through artificial intelligence-based diagnostic tools, would have already known her risk for cancer. If this risk was already shared with her and her HCP well in advance, this would have made her more alert, her HCP, her doctor, more alert, and they would have together, in a participatory way, managed their disease together. She wants, my mother, and for all women out there, we do not want this one-time consultation with our HCP. We want this to be a lifelong journey. We want this to be enduring. We want it to be consistent. And we want it to be like a partner approach where women make the decisions themselves along with their HCPs. Imagine in my mother's journey where the doctor, and because she knew that she's already has the propensity to cancer, they would have pre-decided their mode or their approach to dealing with it once it happened. This would have saved us so much time and so much pain, and it would have been so much easier for my mother to navigate her journey and know what to expect. We want information to be exchanged in a timely way, and again, for women, it's not just about the disease, it's about the emotions and the psychological impact that also needs to be addressed. We want the women to feel confident, to be listened to and respected, to receive fast and easy access, and benefit from coordinated, individualized, end-to-end support. Now, you will ask, this is great, you have women-centered cancer care identified, so what exactly is Roche doing? Now, we have tangible experiments already in place in different parts of the patient journey of a woman in different parts of the world. We have from funding and financing, early detection, communication, capacity building. We have many, many such experiments already going on the ground. But today, I would like to share with you a couple of these examples, hopefully as an inspiration, something that you can take back to your markets and learn from them. Let's see the video, and the first story is about Kenya, where we worked together with multiple stakeholders in the ecosystem to really use the taboo of breast cancer examination, turned it into a strength. And I'd like to watch, I hope you can watch this and see how we use the taboo as a strength and how we are shaping breast cancer diagnosis in Kenya. Can we have the video? Okay.
It's a story about access, it's a story about women, and it's a story about leadership.
My grandmother died from cervical cancer, and it wasn't found out until it was too late. My grandfather had prostate cancer, so I felt that their health-seeking behavior, and certainly culturally and socially around them, it wasn't something that was easy to discuss because, it revolves around your reproductive health system. So naturally for us as Africans, that's not something we easily speak about.
Africa is a very interesting place to work in, and it's because we are predominantly a patriarchal society. But when it comes to how the community works, women are at the forefront. When it comes to how children go to school, when it comes to how the man is fed, it's the woman who becomes a pivotal part of how the community works.
If you look at the whole continuum of care, from the awareness and the screening part, the most fundamental part, a lot of our women do not understand, first of all, the disease. For example, in Kenya, in the local languages, we don't even have a name for cancer. So you can imagine today if a woman has an issue, maybe a lump in her breast, how does she go and explain that to a healthcare provider? And even how does the healthcare provider understand?
Cancer, in many aspects, is not even something that we understand at that community level. If we talk about malaria, it's very easy, and it only was until recently that we're able to translate cancer to saratani in Swahili, which is still a very deep Swahili word for anyone, say, even in Kenya, to understand.
Women generally do not go for screening. The level of awareness is low, and breast cancer and cervical cancer, if detected early, can actually be cured. They can also be prevented if only the women knew what to do.
In Makueni, when the clinic was actually incepted, most of these people used to be terminally ill. Cancer was the number 3 cause of mortality in our facility.
This gives cancer the image of being a death sentence. And personally, I'd like to change this narrative.
When you look at the challenges that the cancer patient is facing today, and in countries like ours, which are the low and mid-income countries with limited resources, governments sometimes struggle to prioritize, especially non-communicable diseases. About 4 years ago, we had a partnership as Roche Kenya together with the Ministry of Health. The leadership felt that it is important for us to reach out to another affiliate to learn what they were doing different, so that then we can also make our partnership better. And so we reached out to the Colombian affiliate, and we worked on a peer-to-peer exchange program to learn how they were working. The market dynamics are very similar in Colombia and Kenya, but they were way ahead of us in universal health coverage. So I traveled to Colombia to meet my peer, who was then head of access and policy, and tried to learn from the internal teams what they were doing, how they were able to ensure that patients were getting standard of care and better therapeutics. That is when I had an opportunity to visit the Pink offices, which was a partnership between the Colombian affiliate and a hospital within a faith-based organization. And of course, with a lot of consultation, both internally and externally, with different stakeholders, we were able to come up with Empower. with County First Ladies Association, which is an association of the governor's wives within the country, and they were to assist us in creating the awareness, especially at the community level. They give people the confidence and trust because they are the face of the government in the communities.
So about 3 years ago, County First Ladies Association partnered with Roche, Women for Cancer, Africa Cancer Foundation, and International Cancer Institute to plant cancer screening clinics for women around the country. And to date, we have planted 14 dubbed Empower. The purpose of this was to bring screening to the doorstep of the communities.
If you catch the cancer early, you're able to treat it early. Now, the good thing is right now we have a dedicated unit whereby when women come for their family planning services, they are able to access advice and screening on the same. So let's say a woman is uncomfortable, somebody doing a clinical breast examination for them, they're actually taught how to do this at home and what to report.
This empowers them. They get to understand what to look out for in their body in terms of discharges and any abnormalities that they may see. So that when they do go to a hospital to see a doctor, they can discuss these things openly. And we also hope that there'll be a reduction of stigma when they realize that this is a common thing. It's okay to talk about it. And of course, we expect that they will share this with other women in the community because women always share a lot of information with each other.
Na wakati huu nilikuwa mgonjwa, nilisaidia watu watatu. Nikimwambia nenda hospitali waangaliwe. Na mtu akisikia chochote, kimbia uone daktari. Wacha kufikiria ati umeroga.
It's so important to invest in women's health. Women are the backbone of society. They are the nurturers. They're the ones who raise the future generation. And if their health is compromised, it compromises the quality of life of the children that they will raise.
The stakeholders also felt that we need to go a step further. Now, the similarity between Colombia and Kenya now was that there was a lot of stigma on breast cancer, and a lot of the healthcare providers were men. And what they were doing was using blind community health workers for clinical breast examination to make the woman feel comfortable. And I thought that was a very good idea because we are having similar challenges in our country. There's a lot of stigma for breast cancer. A lot of our healthcare providers were men. We felt that the patient story and the patient experience needs to be understood and not in AMREF. Now, AMREF has come in because they are the largest NGO within Africa, and they are the ones that are responsible for training the community health workers with disability.
My name is Kitawa Wemo. I'm the project lead for the AMREF Roche Empower project, which is being implemented across 7 counties in Kenya at AMREF Health Innovations. The Empower AMREF partnership or collaboration is a flagship type of project that works with community health workers who have disabilities, who then use the Empower clinics as channels to reach the communities through community health worker sensitization and activation. So what this means is we will be able to offer community health worker support using community health workers with disabilities, which is the first to happen in Africa, which makes it complex and makes it exciting at the same time.
We felt that we can include the blind to do the clinical breast examination and the deaf to do the cervical cancer screening. So AMREF has come as subject matter expert to train community health workers who have disability and convert the training modules that the government has for this special kind of women.
So I think it was an ingenious idea how they have used the deaf and the blind, trained them to be the community health workers for early screening of breast and cervical cancers. And these community health workers, the deaf and the blind community health workers, actually go out into the communities and test women. And because they are blind, it's easier for the African women to let them diagnose and test their breasts. So it's a very, I think it was a very intelligent way of managing the stigma, managing the taboos, and also uplifting two different underrepresented communities in a nice way. We also have a story from here, from Thailand, and I'd like to invite my colleague Lena, who will share with you our journey in Thailand around breast cancer. Lena, over to you.
Thank you. Hello, everybody. Sawadika. I hope you're having a great day, and it's a real pleasure to be here together with you. My name is Svetelina Müller, and I'm the lead for breast cancer and hematology at Roche, Thailand. I came to Thailand around 2 years ago, and since then it has been an incredible journey. Not only I like it here in Thailand, but my family as well. And with time, they have started visiting us more and more often. Just last weekend, I had the visit of my parents-in-law, and they really had so much fun. You cannot imagine. They went to Khao Lak, they went to Phuket, they did over 12,000 steps a day. Why am I telling you this story? The reason is that my mother-in-law had breast cancer 14 years ago. Yes, 14 years ago. But you cannot see a thing right now. She has fully recovered, and she has the life that I wish for everybody and every patient with breast cancer, full survival. And I really wanted to share that with you because it's an example for me from what I see in the life people could have in Germany, where overall survival of breast cancer is above 90, even 95%. And that's very inspiring to see. I would like to ask you, have you checked what is the overall survival for breast cancer in your country? How much is that in Thailand? Exactly, that's the question that we have been asking ourselves, where we started working together with some of the stakeholders here. And you know, throughout my work, I was really inspired to see many strong personalities. One of those strong personalities that I met was Dr. Youwanuch, who is the president of the Thai Breast Disease Society, with whom we worked very closely together to set up the Breast Cancer Positive Alliance in Thailand. She's one of those stakeholders, but an immense fighter for patient rights. And I'm here today just to share with her as well, with you today, her video and her story of what we have found in Thailand and what we can do together to make a difference. With that, let me share with you her story.
Hello, everybody. I'm grateful that the APPC committee invited me to attend this conference to share and to introduce our project we call the Breast Cancer Positive Alliance. For this project, we started to do with our network since 2021 by the Thai Breast Disease Society with the assistance from Roche pharmaceutical company. Today, I will talk about the breast cancer landscape and accessibility in Thailand. And okay, for the content, I will focus on the 3 points. First, I will tell you on the overview of the landscape of the breast cancer care in Thailand, and we compare in the key countries, Philippines, Taiwan, and Australia. And the second, after we talk about the landscape of overview, we will show you the current status of analysis that we researched in our country on 2021, focus on screening, diagnostic, preparation, treatment planning, and intervention of treatment. And the last is how to close the gap by the TBS. TBS is the Thai Breast Disease Society and the Breast Cancer Positive Alliance collaboration. We know that breast cancer is the most top 3 cancer in Thailand in overall, both male and female, and is it the leading cancer-related cause of death for women. For the cancer in the women, breast cancer is the most common cancer in women. The incidence rate in Thailand is per 100,000 is 35.7 per year. And for our knowledge, we know that for the breast cancer, if we early diagnostic and I treat it immediately, the cancer is curable. So I will show you that what is the gap in Thailand. We use the ICOM breast cancer patient journey to study along the way of them by the screening, diagnostic, preparation, planning, intervention, recovery, and monitoring. Our team and Ipsos is the organization that help us to study. We divide all the factors in the two groups. The red color is represent as the limited policy program or have some issue that have implementation is more fragment of care. And then yellow color represent some area that have existing effort with the potential for development or implement further. The first we focus on the screening and prevention. You see that under universal healthcare, Thailand we have the universal healthcare coverage. The reimbursement is limited to screening and prevention activity, mainly by the breast cell examination and clinical breast examination, not include the mammography and ultrasound. For the diagnostic, universal healthcare coverage pay only the essential diagnostic treatments, such as diagnostic mammography, not screening mammography. He pay for the diagnostic mammographies, biopsy or immunohistochemistry. And for the HER2 testing, accreditation is ongoing for the quality improvement that I will show you later on the next slide. And excellent infrastructure, we have only in the Bangkok metropolitan area, but on the rural area, I think is some infrastructure is have some constraint for the doctor and for the patient to access. And the third is for the planning of the treatment. We know that MDT, multidisciplinary team, is very important for breast cancer care. In Thailand, we have a MDT team that form only in the large hospital, especially in the medical school and the faculty of medicine, not in the rural area. The rural area is, I think, don't have any MDT team. So we need some something to improve, something to have to network together to close the gap of the MDT team. And for the treatment, intervention or treatment, you see that NLEM, we have a national list essential medication. In the detail of the national list essential medicine is provide only the basic asset to anti-cancer that mainly is a chemotherapeutic. And for the recovery and rehabilitation, almost of them is a last cell managed recovery. We don't have any definitive local guideline. We don't have the education or training program for provider or patient. And the last is for the monitoring and management. I think currently we have the fragment alignment. Each network and hospital is at their own guideline. We don't have any international guideline. And about the cancer registry is only in each hospital. We don't have a national data registry for the breast cancer patient. I think it's very important in the starter point to do something. So, and when we see in the screening and prevention, from our research, prelim research in the 2020, on the screening program, you see that in the high income, for the key country that we compare, high income is Australia, Taiwan, and the low middle income is Philippines. Thailand is upper middle income. You see that in Thailand, the policy of the breast cell examination and clinical breast examination is our policy for the breast screening. The mammography and ultrasound is not for the mass screening. We have the study on Thai women on 2019. When the Ministry of Health they promote the breast cell examination for the women who have the regular breast cell examination was significant. Have a survival rate higher than non-regular breast cell examination. A review of the opportunistic mammography screening, we can detect 10 cases of the breast cancer in every 1,000 women, suggests that a high detection rate and is maybe some area of the unmet need. And we will compare with Taiwan. For the Taiwan, biannual mammogram was the most effective strategy compared to the clinical breast examination or only list-based mammogram in Taiwan. It's confirmed that when they apply the biannual mammography regularly, the mortality rate reduction is from the 41% reduction in the stretching from the stage 2, and for the survival rate, it was improved from the 81 to 89 after they introduced the biannual mammography. Compared with the Philippines, on the Philippines don't have any local mammogram screening RCT. The clinical breast examination RCT was conducted between 1996 to 1999 screening. From that study show that don't have any significant reduction of the breast cancer mortality in the clinical breast examination intervention group. So I think for the area of the breast screening by the clinical breast screening or by the breast cell examination, I think we need to explore, and we need to see that for the mammography and ultrasound, how to introduce, how to some patients who have a higher risk is should to receive the mammography and ultrasound and can reimbursement from the national healthcare policy. When we see on the demography, the breast cancer incidence in Bangkok, in the central area and in the north is higher than 30 per 100,000 women. But when we see the mammography distribution in Bangkok, is have mammography per 1 million population is 20 mammography, and you see in the central only 3.1, northern is 1.2, northeast is only 1.2, and in the southern is only the 1.3. It means that it have some equally for distribution of the mammogram machine, and we don't have enough qualified radiologists in Thailand. So I think is for this point we need to think if we the challenge of it, if we introduce the screening mammogram and the ultrasound in Thailand, we do both mammogram and ultrasound because our women have some dense of breast tissue. The mammogram is have a low sensitivity, but we have some limited of the mammogram, limited of the radiologist. So I think is if we on last 2 months ago, Thai Breast Disease Society, we proposed some guideline that the mammography and ultrasound we should to offer in a high risk women. And next we see in the global breast cancer incident, worldwide is 47. In Thailand is 37. When we compare with Taiwan is 73. I think is for the environment and from the nationality of the Thailand and Taiwan is same. So we have some gap. Lower rates of the breast cancer is mean that we don't have any early detection when we compare with Taiwan. So I think we should to explore for this number. And the next challenge is a diagnostic. Diagnostic is the meaning is a diagnostic protocol challenge of the prognosis. What about the cell type of the cancer? Because we know that after we do the biopsy, we need to check both what is a cancer or not cancer. And when we know it's a cancer, we need to stain by the immunohistochemistry to check if they have a hormone receptor positive or HER2 overexpression or have a triple negative, because the treatment is it depends on the tumor type. So when we see that we have some gap of the pathologists in Bangkok. In Bangkok, we have the pathologists 3.6 pathologists per 100,000 population. But in the another part of our country, in the northern is less than 1, is only 0.4. In the northeast is 0.2, and in the west is 0.1, and the southern is 0.3. All of them is less than 1 when we compare. The Bangkok is 3.6. If we have some constraint about the pathologies, it means that we may delay the diagnosis. Approximately, the median doctor delay between the first point of care to the diagnostic date is more than 3 weeks. In the southern, the greater is in southern is 28 days. So I think is the meaning. If we delay diagnosis, the meaning is we must delay the treatment. And for the distance of the pathologists in the rural area, we less pathologists. So when physician or surgeon do the biopsy, he need to send the tissue outside their province. It's maybe very long distance. So I will show you that the triple negative rate in Silan Hospital is 16. In Songkla Nakhrin is 13. In Chiang Mai is 17. In Sri Nakarin, Tharavirod at the northeast is 22. So I think is you see the triple negative is so have some different proportion. And we show you Dr. Supinda. Dr. Supinda, she is a anatomical pathologist that work in the Kongdan University. She conduct the pre-analytic monitoring that have from the support from the Thai Breast Disease Society, because we know that if we know the correct immunohistochemistry, if we know exactly of the tumor type, it means that we can treat in the correct way. Dr. Supinda, she conducted pre-analytic monitoring to get close the gap of the constraint about the pathologist. She applied the Internet of Things. She focused on the co-ischemic time. Co-ischemic time in Thailand that we encourage to all of the surgeons is that to make the cold ischemic time is less than 60 minutes, and warm ischemic time that fixed in the formalin not greater than 72 hours, and they can monitor by the Internet of Things. By the Internet, we can use our mobile phone to check what is the time of the cold ischemic time, warm ischemic time. The report is we can get or not the pathology process the tissue already or not. We can monitor. For this project is spread to our entire area of in the big hospital in Thailand. She compared that this picture is the rate of the triple negative before we start the pre-analytic project, and this is a triple negative after we apply this project. It means that on the past we treat the patient as a triple negative because the tissue is not well prepared. And for this paper that she conduct in Udon Thani and Kongdan University, you see pre-analytic, the triple negative rate is 26. Post is only 12. That he published this research on November 2021. So I think the pre-analytic, the monitoring pre-analytics phase is really important. It is starting point for the breast cancer patient. And the next is for the treatment planning. You see that in Thailand, as I tell you, that the multidisciplinary team is available only in the large cancer center, not in the almost of the hospital in Thailand don't have an MD team. For the systemic evaluation, because we don't have any good cancer data registry, no systematic evaluation. For the mainly of the surgery option is the mastectomy is greater than breast conserving surgery. So I think is in the rural area they have some limited tool for the breast conserving surgery, and for the lymph node, almost of the Thai hospital do the axillary lymph node dissection. That have some patient is maybe suffering from the lymph edema if we do the axillary lymph node dissection. But because we have the constraint about the laboratory, we constrain about the anatomical pathologists, almost of them cannot do the sentinel lymph node biopsy. That I think is a big gap that we need to close. And for the payment, as I tell, that national list essential medicine that is only the basic that is focused only in the chemotherapy. For the targeted therapy and some novel medicine is not covered by the universal coverage. And the next, from the patient factor, as I tell you that for the surgery, is almost of them is a mastectomy, pharmaco and culture behavior. We have many factors to have some barrier to the patient. And the next is for the treatment. For the treatment guideline, we don't have any national guideline. On many years ago, on 2012, NCI he launched some the local guideline on 2012, but it's not well established. It's not spread to another hospital and not updated. And National Health Society Organization treatment protocol is served as only the reimbursement criteria. The last update is on the year of the 2018. So I think it's have some really difficult for the rural people to access for the modernized medicine. And for the targeted therapy, the trastuzumab is I think is we can use only in case of the node positive. For the node negative, we cannot reimburse almost of the patient. So I think is for the drug access, I think is have some not clear if the patient have different reimbursement, because we have the three major reimbursement funding is from the National Health coverage, from the Social Security schema, and from the civil who work for the government schema. And when we check on the hormone receptor positive in Thailand, from the three of the funding is OOP, OCPA, or NLEM is very different, and only the focus on the basic hormonal treatment is tamoxifen and letrozole, and less of the targeted therapy in the hormone positive cancer. And for the no, is immunotherapy is no, it cannot reimburse in Thailand. The patient need to self-pay. For the OCPA is that pay for the government staff. We try to improve the reimbursement in the first line of the HER2 duct treatment. But I think it still have a difficult for the patient to access them. And so why we have the breast cancer positive alliance team, we try to make some collaboration among various stakeholders in Thailand. Is a physician organization, Ministry of Health, and universal health coverage, and the patient group to close the gap that we study that I showed you before. I hope that the breast cancer positive alliance can reduce the premature mortality rate is 1/3 of them by the 2030, aligned with the UN Sustainable Goal. And for our working group, we focus on in the first 3 years, we focus on the improved screening and how to do the data registry, the treatment guideline, and how to make the healthcare policy in Thailand. We make the key milestone in 10 years. For this phase, on the 2021, 22, and at the early of 2023 is a planning phase. And next year, we start to we do as a plan, do, check, act. And the last, we join the breast cancer positive alliance, embed into the Thai Breast Disease Society strategy 2020 to until the 2026. On Thai Breast Society, we will focus on the breast center certified. We will certify the center that have the good pre-analytic to prepare the tissue and create the center standard and key performance indicator. And the last one, we try to accredit the breast center according to the sizing of the hospital. It may be accredited is a breast clinic, breast center, and the last is an excellence breast center in the medical school. And the second pillar, we conduct the TBS guideline. This year, we produce a genetic test guideline, breast screening guideline, and breast margin for breast conserving surgery. And we have many ongoing breast cancer planning treatment. And the last, we start to make some program that certify the training program is a breast surgeon and new speaker incubator camp. So I think that in our main project can make a network and collaborative with the breast cancer positive alliance to conclude that the last, I think not the last, we conclude that all our effort can make the Thailand have a Thailand National Committee to improve breast cancer care management collaboration among the diverse stakeholders. So I think it's the time of the Thailand to have a national committee to improve breast cancer. Okay, thank you very much.
And so I hope that both these examples gave you how comprehensive. In the first one, it was more about an idea where we actually put it on the ground, and with the Empower clinics, how we are using communities with disability to work with communities of women. And the second one is like a comprehensive approach on how we did the need gap analysis and then put together a alliance of stakeholders that is driving the way forward for breast cancer and for women with breast cancer in Thailand. Now, based on both these and all the different examples that we are working on in Roche, and some of the great work that all of you are doing on women's health, we've come to recognize that if a true shift has to happen, we need three big things. The first, we need enough evidence, and when we say evidence, we need credible evidence that can really shape the way forward, that can really move the government policies, that can really shift the thinking of stakeholders. The second big pillar that we feel is needed for any change to happen in women's cancer is ecosystem integration, where we actually put in pilots such as the Empower clinics in Kenya, where we bring together different communities, different ecosystem players to make an on-the-ground change, which can become like an evidence, a proof of evidence that if investment is made in women's health care, it can change the way women, society, and economic benefits are achieved in the country. And the last, but the most important thing, is to bring together a group of stakeholders, to bring together influencers, and to bring every voice in the system together so that we can actually change the way governments make policies, the way we invest in women's health care. So based on all our learnings, we felt these are the three big pillars of change that we have to implement. And we are very passionate about doing this in Asia. And for that, before I come to this, I think we are putting together an alliance for APAC Women's Cancer Care. This alliance has two different steps. We have a regional level alliance where we are bringing together different kinds of players, ecosystem players such as yourselves, patient advocacy groups, industry players. We are bringing together global players together to create this, to bring together a set of people who bring their experiences, their wisdom, who can help policies shift at a local level. And the second part of this alliance is in-country local alliances. So we are bringing together in Thailand, Malaysia, Philippines, Vietnam, India, and Indonesia a group of stakeholders together who will work with this regional level alliance to make a shift in women's healthcare policy. Now this alliances, as you all know, is so important to make a shift happen. And I want to use Dr. Fatima's quote here because this is not going to change or give results in a fast way. This is a manifestation of a deeper and difficult problem, societal problem. And those kind of problems don't go away with one initiative. This has to be a long-term commitment. And I know that each one of you is doing some great work in your markets, in your countries around women's health care. But these individual works is not enough to make a shift happen. We have to join hands. We have to work together if we really have to make a change happen in Asia or in any other continent that we want to work together. The work with all the alliances that we have been doing as Roche, but also the work that we were speaking about earlier, like the Personalized Care Alliance that IAPO was part of, we all have learned that when we work together, that's only when we can move mountains. And women's health care is a big mountain that needs all of us to work together. I want to end with this quote on Mother Teresa. She's from India, I'm from India, so it's very close to my heart. I can do things you cannot. You can do things I cannot. But together, we can do great things. So here I'm calling all of you to really come together in Asia to make a big shift happen for women's healthcare. We need to start a movement, and that movement only begins when each of us joins hands to make this change happen. Thank you very much. And I now lead in to invite my colleague, because this is where we want to sort of call for action. We want to bring your voice into this discussion and see how we can together shift this big mountain around women's healthcare in Asia.
Before we start the discussion, we would actually like you to take some action. The action that you can take right now is to sign up to be part of the alliance we're building together. We would like to invite you to scan the code, the QR code that you either have at your tables here if you are in Thailand, or if you're watching us virtually, please take a picture of the code that you see on your screen and please join us together. You're welcome to share your details and we would get in touch with you at a later stage. Just maybe if you take a couple of seconds to do that, that would be greatly appreciated.
And while you're doing that, I'd like to hear a few voices from the group. You know, how are you feeling about this? What do you think is really needed to make a shift? What resonates with you when it comes to changing women's healthcare in your markets? Anybody would like to share their voice?
You were listening for such a long time, so now it's your time to speak.
Yes, Bhuvi?
Hi, we've got from the virtual participant statement here. It is from Melissa Lim from the Society for Cancer Advocacy and Awareness, Kuching. It's East Malaysian country called Sarawak. So she said, recently the WHO commented that there is no improvement in survival or significant benefit in breast cancer screening if we are unable to provide early treatment for the women in the rural communities. So it is the fear of knowing that ultimately leads to late treatment and hence poor prognosis in most women. How do we come together to empower women to overcome this fear and take charge of their lives? Losing one's breast is not something to be taken lightly. Not every woman is strong enough to overcome that. Melissa's mom herself is a breast cancer survivor.
Thank you so much for sharing, Melissa. Really insightful. And a very provocative question. I think all of us need to think about that. So I think we have another comment as well here from Thailand.
Actually, they would like to share their own experience. Can they share in Thai and then I can help translate?
Sure.
Sure.
ขอบคุณค่ะท่านผู้ดำเนินการในหน้าที่นี้นะ
Thank you. I would like to apologize for speaking in Thai. I would like to share my personal experience that I am a survivor of breast cancer. I had an operation in 2017 and I had an operation, chemotherapy, as well as radiation, as well as medication. It has been ongoing for 5 years. In this year is the 6th year, and if we follow the regimen prescribed by the doctor, we can survive breast cancer. Today, I can enjoy work and I can dedicate my body and my mind into my work without stress, and this lack of stress helped me survive. I've been giving my time to volunteerism by sharing my experience with other breast cancer patients on how to maintain our mental health and survive breast cancer. I also became a village health volunteer. This is a direct experience that I share with other people in the community as well as relatives who can follow our examples in their daily life and live a happy life. Thank you. ยังมีอีกคนหนึ่งนะคะที่จะมาเล่า
Hi, good morning. My name is Ara Lanorio from the Philippines and representing a Philippine Alliance of Patient Organization. Maybe I could share some experience because in our family, I had 2 family members. My brother was passed away last year because of acute myeloid leukemia, also cancer in the blood. And I had a sister who was once diagnosed of uterus cancer. What's the most important thing here is the support of the family members, especially as long as you have the support of your family, everything will be lifted up, your spirit, and even the medication, even the treatment, during the process of treatment, family support is always a #1 factor for, especially for the Philippines, because in the Philippines, family always matters. Thank you.
Yeah, thank you so much for sharing that.
I agree with you. Thank you.
The question is that we know and we have all these experiences in the room, and each one of us has a strength, and individually we are doing great things, like I said. But is there merit in joining hands together, creating something like an APAC Women's Cancer Care Coalition, where we bring together all our energies, all our experiences to shift this big mountain for women in APAC? Like to hear more from you. Yeah, go ahead.
Hi, thank you so much. Again, being an industry partner, I think it's amazing, and we've really seen the power of alliances and coalitions in other regions. One of the challenges we have in APAC is we have the lack of an industry association like pharma in the rest of the world. We do have local associations, but because we lack that regional one, unfortunately, alliances and coalitions have kind of dwindled, and they're either driven by one company and nobody else joins hands. And I think it's about time we change it. So any feedback or perception on that, because we'd love to join this alliance.
Perfect. We'll welcome MSD. What Roche has done is 2 things. We have brought together a project management secretariat, which is a regional company called CMI, Crowell and Morning, who's going to keep, if we do decide to join hands and create an alliance, who's going to keep a neutral body as the secretariat, as the alliance partner who manages the day-to-day governance of an alliance such as this. We know alliances dwindle because each one of us brings in different values and strengths, but also because of that, sometimes we need to be kept together, and CMI's role is to keep us together. The second thing that Roche has put together is working with the economists. We are trying to create a white paper on the gaps around women's healthcare in this region and comparing it with other advanced markets so that we can identify these policy tools that will help us. But this alliance can only work if we all join hands, and industry partners, including other pharma companies, but not just pharma companies, other partners also join in, and together we all as women make enough movement happen for women's healthcare in Asia. So if you feel like you can bring value to such an alliance, please join the QR code and we will work together. As Roche, we do not want to create the agenda ourselves. We want to bring in people who can help us to start this movement and create a joint agenda. So if you are interested, we'll be happy to create a forum as a next step where we can come together and discuss what should be the goals of such an alliance. How should we take it forward?
All right. I think that we have a WhatsApp call. Somebody online? Okay, we ignore. That's fine. Maybe that's a good segue, actually, when we can get a little bit more concrete. Sorry, we have one more comment. So sorry, before we continue, please.
Yeah, this might be, okay. Of course, we are joining the Alliance. We are joining your efforts to give this wonderful advocacy strength. But of course, we also wanted to invite other peoples outside this sector, probably our friends from the media, the television makers, producers in the film. I think it's very important for them to join to battle the stigma that face the patients, you know. For example, in the telenovela, in the movies, if there is a bad character, they will give him or her a cancer so that that person will die. And you know, eventually these things comes into the mind of the children.
Yeah.
And as they grow old, the stigma gets bigger and bigger. I think it has to stop.
Yeah. I think you bring a big point. It's not just the healthcare industry, but we need to go beyond the healthcare industry so that we can make this movement really successful. And you know, we are looking at banks, we are looking at FMCG organizations, and we are looking at media. But only when we all join hands can a movement truly change the way things are happening in Asia. And as a woman, as a daughter, as a wife, as a mother, I'd really like to invite all of you for the core purpose that we all started in this journey. It was about making a shift. It was about making a change. But like I said, a change can only happen when we are together. So I move to the next one.
Thank you so much for all the valuable comments. And as said, if we can maybe become more concrete about prioritizing the initiative and just thinking, okay, so if you realize that there are so many gaps that we talked about in women cancer care in APAC, we already heard about many of those gaps, and I think you know about them locally as well. So we thought it would be useful if we can just have a poll today together, just to find out what you think are the most important gaps that we have to address. And that's why we would like to encourage you actually to rank those gaps. If you could kindly join slido.com. So you need to go into the application slido.com and enter the number which is displayed here. So please enter as a code 2898789. So there is an active poll.
Song pet, cow pet. I forget the 7. Pet cow, I forget the 7.
So 2898789. Please kindly join us for the poll. You can do it very easily. Please just go to slido.com.
And we are seeing some results.
Yes. We can already see some action. So whoever is voting, we can immediately see the results here today. It is just great to have all these discussions and to brainstorm, but at the end of the day, if we don't have something concrete as an opinion out of this group, I think it is very difficult to move forward. So we really want to encourage some action here in the team as well. Thank you. Thank you for participating. Okay, so we have a couple of more people joining. So we have two things that appear to be the most important ones so far. Maybe with more people joining that might change. But so far we have equitable and timely access to optimal treatment as a priority, as well as women cancer screening and timely diagnosis. Let's see if some of the things are moving. All right. When we were analyzing all the data, and you saw it as well in Thailand and also beyond, we just found out that there are so many different areas that are still lacking behind if we compare that to other nations. But we need to prioritize. We need to find where can we make the biggest impact now with the least effort, because patients are waiting. And I think it's very nice to start with some of those topics already now together.
Well, in my opinion, I feel like, the objective of any movement is to ensure that we have sustainable access and sustainable funding of such a movement. We don't want to start something, with all this rigor and, enthusiasm, and then over a period of time it dies out. And that means we need sustainable funding for such an initiative. And only when the governments of every market start investing in women's healthcare can true shift happen. So for me, if you ask me, I would say like women-centered cancer care funding by government, like to me is like an important, ultimate goal and milestone that we want to achieve so that we can make a true shift happen.
And I agree with you. I have noticed that there is a very big difference between the countries. Having lived myself in over 10 different countries, right? If you compare how health is valued in the different areas and what is the percent of GDP spent in healthcare in the various locations, it differs a lot. And I think personally that's not fair. I feel it should not make a difference, and where you live should not determine if you live. And especially when it comes to women cancer care, where we really talk about a societal impact.
Great.
But all right, so thank you. The first vote so far has been done. We have the priorities of women cancer screening and timely diagnosis, as well as equitable and timely access to optimal treatment. Thank you so much for those of you who voted. Maybe then we can continue to the next question. And this question is, what is your dream for women-centered care? If you could share this dream in 1 or 2 words. So please describe this dream.
And you have to use this board?
We would also encourage you, so for those of you who are online, to type it as well in Slido. You have the chance to do that. But also for those of you who are here sitting with us in Thailand, please go to the board. We actually have a physical board. Yes, no more digital. So finally we can also do something here directly in Thailand. So please go up to the board and really put your words there, that put your dream for women-centered care in 1 or 2 words. That would be really nice.
No cancer, no death.
Health literacy, okay, I think that's very important. So
Effortless.
Women-led actions. I know we have a number of strong women here, so I'm sure we can do that. Equity, I like a lot. I think that's really important, and it varies a lot, I think, in APAC. Assessment. Thank you. I think we are getting a very good picture of what we can be striving to achieve. Just listen. I like this one as well, because I really feel, and that's why we ask you, we want to listen to what you think as well needs to get done here.
I think one thing that's really famous in APAC or Asia is tiger moms. You know, moms who are, you know, really behind their child's development, their child's progress. And I think we have to be these tiger women now for women's cancer care. We have to pursue this topic with unrelentless, consistent, persuasive kind of way forward. Only then a true change can happen. But a true change can only happen if we all work together. So looking forward to having many of you join the Alliance and having a subsequent meeting with all of you on how we can make a true shift happen for women in Asia and women living with cancer in Asia. Thank you so much for joining us today and for listening to our passionate story, and looking forward to joining hands with more passionate people soon. Thank you very much.